very much. I'm happy to be here to talk to everybody today. Today we're going to talk about NAVA, which is neurally adjusted ventilatory assist, and I'm going to make this talk specific to newborns. So let's click here. Just so you know that conflict of interest or my disclosures, I speak for the McKay-Gettinger group that makes NAVA, and then for Chiesi, which makes CuraSurf. I work in Ebi Children's Hospital, which is in Toledo. We are a 72-bed NICU level 3B. We don't do cardiac surgery. We don't do ECMO. We have about 950 admissions a year coming in, and about a third of those are outbound, so we have a unit-based transport team. We are not an academic facility. We have residents, students, but we don't have fellows. And our little group of neonatologists is a private practice group who are doing all this clinical work and research. So, quick review. Signal starts in the central nervous system, comes down the phrenic nerve to the diaphragm contracts, the chest wall and lung expands, and as you take this breath in, you get this change of flow and volume, and that sends a signal to the ventilator, and that's the flow trigger that tells the ventilator then to give an assisted breath. With neurally triggered ventilation, we're picking up the signal much earlier. So the neural trigger starts when the diaphragm gets excited, and then the ventilator will give the assisted breath. So to look at it again, the signal comes down the phrenic nerve, excites the diaphragm contracts, then air has to move. So once that air moves, it then tells the ventilator that the valve is open, and the ventilator then delivers a breath to the patient. This is synchronous for initiation of the breath only, and it responds to the patient's effort. The patient actually has to move air in order for the flow trigger to be useful or to go. We measure the EDI, or the electrical activity of the diaphragm, with a specialized catheter. It looks like a regular nasogastric tube, but then it's also got an electrical cable built into it. And there are little electrodes on the end over here that we position right at the level of the crural diaphragm. And that can then detect when the electrical activity of the diaphragm begins, how much electrical activity there is, and when it ends. And here you can see that the tip is in the stomach. It can be used as a regular feeding tube, and the electrodes are positioned at the crural diaphragm. NAVA works with the signal starting in the brainstem, coming down the phrenic nerve to the diaphragm. At that point, the electrodes here in the catheter detect the electrical activity of the diaphragm and sends the signal back to the ventilator. So when the diaphragm starts to contract, the ventilator is now ready to give a breath synchronous with the patient, not only for the initiation of the breath, but also depending on the amount of the electrical activity for the size of the breath. The lung then inflates until it reaches a certain point where the Herring-Brewer reflex kicks in, and that provides negative feedback to the brainstem, where it turns off the signal from the phrenic nerve to the diaphragm. That turns off the signal to the ventilator and immediately turns off the flow to the baby. So this is now synchronous for initiation of the breath, size, and termination of each breath. And it responds to the patient's drive. So it's all about the signal coming down here as opposed to the flow trigger, which is effort. So here we have a patient on SIMV pressure control, and just to orient you to the servo, this is the pressure, this is the flow, and this is volume down here. And then on the bottom, we're going to bring in the electrical activity of the diaphragm. And over here, you can see that this looks like we have pretty good ventilator-patient synchrony. These red lines over here are the flow trigger. And what we can see is here we have a flow trigger with a control breath. Here we have no trigger, and there's a mandatory breath. Here's another flow trigger for a control breath. Here's a support breath. And all these other breaths look like there's appropriate triggering. However, when we bring the EDI signal in, which is down here, And it's the EDI peak for inspiratory effort and the EDI trough here, which is the tonic activity of the diaphragm preventing de-recruitment of the lung. And we superimpose it up here with PS standing for pressure estimate. We superimpose it. We can see we're not doing as well as we thought. If we start with this first breath that there's no flow trigger, indeed, there's no neural trigger either. This baby is not breathing and he gets a mandatory breath like he's supposed to. This flow trigger is pretty well timed. This one's well timed. This support breath is way late. This one is a little bit late. This breath is missed completely. And as we go through, you can see that sometimes we're initiating appropriately, and many times we are just missing breaths altogether. But remember, synchrony is more than just initiation of the breath. It is also the size and the termination. And you can see over here, the baby wanted a bigger breath than he got. Here, the baby wanted a very small breath. Here, the baby wanted a smaller breath, and we forced in this extra air. And in this sequence over here, the baby is trying to recruit, and yet we continue to give the two size breaths that we've programmed into the ventilator. In this screen over here, we're going to see a number of different synchronies, asynchronies as well. And this is on the servo U. The first one was the servo I. And again, we have pressure, flow, and volume. When we look like we've got good flow triggering all the way through, but when we superimpose it, you can see once again, our asynchronies are very obvious. This flow trigger here is a false trigger. This over here is a missed trigger. Here we have, again, another false trigger. This one's not bad. This one is missed. And as we go through, you can see that this patient has some significant asynchrony. So there's our mistriggering, there's our false triggering, pressure and termination asynchrony, and trigger delay, pressure, and termination asynchrony. So in as little as one sweep, one screen, we are seeing almost every type of asynchrony that we know about. And it is no surprise when babies are on conventional ventilation that they are pretty uncomfortable. And in the adult world, why patients hate it and require a lot of sedation and sometimes even paralysis. This is a baby that is not intubated. However, there is a NAVA tube in place, and this NAVA tube is positioned at the level of the crural diaphragm. And what we have over here is one brain, which is the baby's brain, controlling the biologic diaphragm, but through the NAVA nasogastric tube, the brain is also controlling the mechanical diaphragm. And if this brain is able to control both diaphragms, as I play this, you should be able to see that these two should be just about identical. Now, you're not going to be able to see microsecond differences, but what I want you to do is look at fast and slow, deep breaths and shallow breaths, and you'll be able to see synchrony. So you can see as the baby speeds up, so does the mechanical diaphragm. As the baby slows down, so does the mechanical diaphragm. So this baby's brain is now controlling two diaphragms. So comparing conventional ventilation to neurally triggered ventilation. The patient controls with a flow trigger the initiation of the breath, and therefore in some modes they can control their rate. Whereas the neural trigger allows the patient to control initiation of the breath, inspiratory time, rate, peak pressure, and termination of their breath. And peak pressure can also be considered tidal volume, depending on how you're measuring it. With conventional ventilation, it's all those buttons that we're learning how to put in there. FiO2, peak pressure, tidal volume, depending which style you like, inspiratory time, breath termination, and minimum rate. Whereas the neural trigger, we put in FiO2, PEEP, and then the three new things we're going to talk about today, the NAVA level, apnea time, and the peak inspiratory pressure alarm. As I said, with conventional, synchrony is initiation of the breath only, with NAVA, initiation, size, and termination. The flow trigger is based on the patient's effort, whereas the neural trigger is based on the patient's drive. When breathing, we talked about synchronous for initiation only, and when breathing, the ventilator is synchronous for initiation, size, and termination with NAVA. However, with an apneic patient in conventional ventilation, when a baby is apneic, they get pressure or volume control depending on the style of ventilation you've picked. And in neurally triggered ventilation, they get pressure control ventilation. So an apneic baby gets essentially exactly the same ventilation on either mode. The difference is on conventional ventilation, when they do breathe, they synchronous for breath initiation only. But with NAVA, when they do breathe, they synchronous for initiation, size, and termination. This is a summary of slides that looked at asynchrony or synchrony with NAVA compared to conventional ventilation. And they're describing it here as AI, or asynchrony index. And that means the percent of breaths that are asynchronous. So you can see with NAVA here on the bottom, about 5% of the breaths are asynchronous, whereas conventional ventilation, about 28% of the breaths are asynchronous. Remember, with conventional ventilation, that 28% asynchrony is initiation only, whereas this 5% of asynchrony is initiation, size, and termination. So a much higher bar, and yet much superior synchrony. The next few slides are going to be very busy, but what I want you to do is just focus on the themes. I'm going to talk about clinical studies in invasive NAVA and then in non-invasive NAVA. So here you can see the studies on the left-hand side, and on the right-hand side are the major findings. And I've tried to color code them to make them a little easier to see. So you can see the themes that are coming up. As we switch from conventional to neurally triggered ventilation, we see decreased peak inspiratory pressure, no adverse patient effects, which is important. Again, decreased pressure, decreased work of breathing. Improved patient comfort, again, decreased pressure, decreased FiO2, more studies with improved patient comfort, and the theme of decreased pressure continues. Intubated time comes down, length of stay in the PICU in the one study was decreased as well. And now you can see that the PCO2 was better and the pH started to improve. Improved AA gradient, or form of oxygenation again, and the same theme showing up. Decreased peak inspiratory pressure, improved patient comfort, a higher extubation success. And the last slide for invasive NAVA, the same theme showing up study after study after study. Decreased pressure, decreased work of breathing, and improved patient comfort. Studies with NIV-NAVA show similar themes. Improved synchrony, and this is a big deal because with non-invasive ventilation, synchrony is very difficult. The enemy of the flow trigger is an air leak. But because we're detecting synchrony from the electrical signal in the diaphragm using these electrodes, air leak is not an issue. So even with a 100% air leak, as that first slide that I showed you, that first little video, we are still able to achieve excellent synchrony. So we're seeing improved synchrony, decreased work of breathing, better extubation success rate, and again, the same thing with decreased peak inspiratory pressure, decreased FiO2. Same themes again, improved synchrony, decreased pressure, some of them showing no difference in extubation success or higher extubation success. So some of these answers are still a little bit unknown. Reduction in clinically significant events, Brady's and DSATs, decreased pressure, decreased apneic episodes, improved synchrony, improved extubation success. So based on this, indications for NAVA in neonates. If your clinical goal is to have synchronous invasive and non-invasive ventilation in ventilated patients, if you'd like to optimize your patient ventilation interaction, if you'd like to increase patient comfort and decrease the use of sedation, if you'd like to do all this while improving blood gases and decreasing peak pressure or tidal volume, allowing patients to recruit their lung when needed to avoid atelectasis and possible atelecta trauma, to eliminate the negative effects of air leak at the invasive or non-invasive interface, and as another option, for non-invasive escalation for patients failing NIPPV or CPAP so that you can avoid intubation or reintubation. Additional uses as a monitor. It can be used for the evaluation of central versus obstructive apnea because it's looking at the signal from the brainstem. Evaluation of diaphragmatic excitation related to possible phrenic nerve damage. Evaluation of ventilatory drive related to acid-base imbalance. Looking at the ventilatory drive in our VLBWs, and also the evaluation of adequate diaphragmatic rest. Contraindications to NAVA. If you can't put a catheter in, such as a tracheoesophageal fistula, pre-op, there's no esophagus to put it into, and post-op, you have a fresh suture site. If you have facial anomalies preventing safe placement of the catheter, or if you have a gastric perforation, you don't want to put another catheter down there. Another contraindication is if there's no respiratory drive, either from heavy sedation, analgesia, or paralysis, or if you have an abnormal brainstem or respiratory center, such as a brainstem malformation, hemorrhage, or severe hypoxic encephalopathy. So in the beginning, I said to you that there are three new things we're going to talk about, which is the NAVA level, the peak pressure alarm, and the apnea time. So I also said to you that babies on NAVA can choose what they want. They can pick their own peak pressures or tidal volumes breath to breath. And to do this, we allow them to provide proportional assist using the NAVA level. We advise you to set that peak pressure limit very high. And the questions we wanted to answer was, is this safe? When we change the NAVA level, what actually happens? And what peak pressures and tidal volumes do they choose when we allow them to choose anything they want? So let's start talking about the NAVA level. The NAVA level is a proportionality factor that converts the EDI signal into a pressure. It's a mathematical formula. But in reality, what I'd like you to think about it as a distribution of the work of breathing. So the higher the NAVA level, the more work of breathing the ventilator does. And the lower the NAVA level, the more work of breathing the patient does. And our goal is to unload the work of breathing from this patient in respiratory distress to the ventilator without over-assisting the patient. Keep in mind, the ventilator is responding to the patient's respiratory drive. That's the neural trigger, but it's supporting the respiratory effort. Looking at it another way, this is a little cartoon that I put together, which really helped me. This is a machine that you can see in the gym, and I don't know if you can see me in the picture, but if you think about this as doing pull-ups, so when you do a pull-up, you inspiring, expiration, inspiration, expiration. And if you're like me and you go to the gym, this is a very hard thing to do when you're just hanging from one of those bars. So I develop respiratory distress. The first thing I do is I start to grunt and pull myself up. When that fails, I start to retract. I use accessory muscles. I bounce, I bend my knees up, and I try to cheat my way up. And if that fails, then I need to go to the ventilator. And this machine here is the ventilator. And for those of you who are not familiar with it, you sit on this thing with your knees here, and you hold the bar. And then you enter weight over here to unload your weight to the ventilator. So in my case, let's say I weigh 200 pounds. If I put 0 weight on here, I would then have to pull up 200 pounds. But if I put 50 pounds on here, then I would only have to pull up 150 pounds. So the more weight I enter over here, the easier it will be for me to do these pull-ups. So now let's look at our volunteer. So Kathy is on the machine over here, and she's pretending that she can't do any pull-ups. She is in respiratory failure, and she's struggling to do it. So what I'm going to do now is I'm going to increase her NAVA level, and she is able to do pull-ups about halfway, but she's still not unloaded enough. So I'm going to increase her NAVA level further. And now she's able to do pull-ups that go all the way to the top. So let me ask you a couple of questions. If I increase her NAVA level even further, is she going to fly off the top of the machine? So what's going to happen is she's going to just hit the top of the machine. She's not going to fly off the top. But what is going to happen is as I increase her NAVA level further, here we go, you can see that what happens is she only goes to the top, but look at her work of breathing. She is now able to do this with minimal effort. So let me ask you these questions now. Even though I've unloaded Kathy and I've made it very, very easy for her to do these pull-ups, she decides when to do the pull-up. She decides how fast to do the pull-up. She decides whether to go halfway or all the way. She decides whether to come down to expire half or complete. In other words, she continues to make every decision about her pull-ups, except I unloaded her work. And that's the principle of the NAVA level. We unload the work of breathing, but we still give the baby complete control of when and how to breathe. Now let's go to the next concept, and then I'll come back to NAVA level, but because I've got this little vignette here, let's start with a peak pressure limit. So if I now take her and I'm going to peak pressure limit her. So let's limit her peak pressure. I'm not going to let her do a pull-up any higher than there. That's her peak pressure limit. So even though she's completely unloaded, she can never go higher than where I've set the limit. And when we get to the peak pressure limit, I want you to remember this little vignette and understand that I'm asking you to take this peak pressure limit to the top of the pull-up so that she can always do the largest pull-up or the biggest breath she wants to take. She's allowed to do that, and we're not limiting her breaths or her pull-ups over here and causing atelectasis. So it's kind of cute in the gym, but does this hold up for babies? So what we did was we did a titration study where we started with a NAVA level of 0.5 and we went up every 3 minutes to a NAVA level of 4. And what we found is at the low NAVA levels, we were not providing very much support to these babies until we reached a certain point where after which, even when we doubled the NAVA level, we kind of had this plateau where the babies were getting no more pressure than what we were giving, but instead their respiratory drive dropped very, very low. So we suppressed their drive, but we didn't give them any additional pressure. And we caused that point where they went from increasing to plateauing the break point. And this is the Herring-Brewer reflex at work. When they reach their optimal inflation, they turn off the signal. So if we're providing them with a whole lot of assistance, they turn the signal, they turn it off very quickly because they don't need much of a signal in order to generate the pressure that they're looking for and inflate their lungs. So when we looked at this as collective data and we looked at babies under the break point and over the break point, we can see that under the break point, they're being under-supported. Over the break point, they're adequately supported. But if you get up too high, you actually suppress their respiratory effort. So we want to ventilate them somewhere around here at the break point. And we'll get to our starting settings a little later. Looking at this another way. This is a graph where we're looking at peak pressure on this side, tidal volume on this side. The green line is the amount of peak pressure or tidal volume being delivered. And the red line here is your EDI, your tonic EDI, which is the peak minus the minimum, which is what the formula looks for. And the red bar over here is the biologic diaphragm, and the green bar is going to be the mechanical diaphragm. So this is what we would like to deliver up here. And this baby's in respiratory failure, so you can see he's unable to get the size breaths that he needs. So now we start to increase his NAVA level. And the biologic diaphragm is getting slightly unloaded, but the mechanical diaphragm is starting to contribute. And as we go up higher on the NAVA level, the biologic diaphragm gets more unloaded and the mechanical diaphragm starts to contribute so that the baby can get up to their desired peak pressure or tidal volume. However, if we continue to increase the NAVA level, you can see that Herring-Brewer only allows us to deliver what the baby wants. But by increasing the NAVA level excessively, we take the biologic diaphragm out of play and we're doing it all from the mechanical diaphragm, which is not a good way to continue to allow that diaphragm, which is a muscle, to continue to exercise. And note that the peak pressure needs to be set high enough that these babies intermittently can take big recruiting breaths. When we wean a patient, so here we have this baby who is sitting at the break point who's starting to get better. So now, as we wean the NAVA level, you can see that the diaphragm, which is now getting healthier and recovering, the biologic diaphragm is starting to do more and more work as we take away the mechanical diaphragm. And even though we're weaning the NAVA level, the baby is now able to achieve their optimal inspiratory requirements because their biologic diaphragm is repairing. Until such point, we come off mechanical diaphragm completely. We go to a NAVA level of 0, and the biologic diaphragm is doing all the work. The next thing I ask you to do is set the peak pressure limit high. So here's a little video that tells you what the peak pressure limit's all about. So let's just watch this briefly.
Setting the peak inspiratory pressure alarm. In conventional ventilation, the peak pressure alarm protects the patient from sustained inadvertent high pressures. The peak pressure delivered is limited to 5 centimeters of water below the peak pressure alarm limit. The new NAVA user may be inclined to set the initial peak pressure alarm at 20 centimeters of water to protect against barotrauma in the event the patient takes a large breath. In this panel, each breath pressure limits at 15 centimeters of water despite a high peak EDI signal. This suggests that the neonate would like to take a bigger breath than is permitted by the ventilator alarm limits. When the peak pressure alarm is increased to 40 centimeters of water, the neonate is now permitted to take as large a breath as desired. As seen in this panel, the neonate takes progressively larger breaths that appear to function as sigh or recruiting breaths. Once the neonate has sufficiently recruited alveoli, the respiratory drive decreases. This is reflected by a decreased peak EDI and lower peak pressures. It is therefore important to avoid limiting the peak pressure so the neonate does not develop progressive atelectasis. Key points to remember. The peak pressure delivered is limited to 5 centimeters of water below the set peak pressure alarm limit. Adjust the peak inspiratory pressure alarm high enough for the patient to take adequate recruiting breaths when needed.
All right, so is this safe? What peak pressures and tidal volumes do they choose when we allow them to do whatever they want? So we did a study where we looked at 24 babies on NAVA and 12 on NIV-NAVA, and there you can see their weights and gestational ages. And we looked at about 700,000 breaths on NAVA and about 500,000 breaths on NIV-NAVA, so a lot of breaths. These graphs show the percent of breaths on the vertical axis, and on the horizontal axis are the breaths divided into pressures, 5 to 10, 10 to 15, 15 to 20, 20 to 25, all the way up to 30 to 35. And all these babies had their peak pressure limits set at 40. And as you can see, our typical thing would be setting a peak pressure of 20 when we do conventional ventilation. We typically start at around 20 over PEEP. And you can see 70% of the breaths are actually much lower than 20, of which over 50% of the breaths are lower than 15. If you did set your peak pressure to 15 to start with, you would fail. This baby would not do well because on conventional ventilation, they don't have the ability to recruit. But on NAVA, even though they pick the majority of their breaths to be very low pressure, they do have about 10% of their breaths at high pressures, 25 to 35. And I believe that these recruiting breaths or sigh breaths are essential to allow the babies to spend most of their time at these very low pressures. With non-invasive NAVA, we see the same thing, over 50%, very low pressures, but you need to have these very high recruiting breaths on this side, which are not very many, 1 out of 10, to allow them to do this. If you are a volume ventilating unit, here you can see percent breaths here, and then volume in mLs per kilo in 1 ml increments. Most units start somewhere between 4 and 6 mLs per kilo, so let's pick 5, which is right in the middle. And if you add all this up together, about 70 to 80% of the breaths are actually less than 5 mLs per kilo, with 50% of the breaths being less than 2 mLs per kilo. To achieve this, though, the babies are still taking 5% of breaths at 7 to 10 mLs per kilo. And they were actually a smattering even higher than that. These breaths, we believe, are vital to allow recruitment so that they can spend the rest of their time here. So the way I picture it is that they recruit lung with a big sigh breath, and then they get progressive atelectasis from these tiny breaths until they recruit again, and then get progressive atelectasis down again. And when we give them the freedom to do this, their overall pressures and volumes fall exactly in the range that we expect from these babies. Finally, the last thing is the apnea time. This is the time the time the baby can be apneic before getting a backup breath. This is not apnea of prematurity. The same concept applies in conventional ventilation. If you set a baby on conventional ventilation with a rate of 30, what you've said is, if in 2 seconds the baby hasn't had a breath, I will give this baby a mandatory breath. So all the apnea time really is a minimum rate for the baby. And here you can see the correlating apnea times with the minimum rate. So if you like to set your apnea time, if you use NAVA at 5 to 10 seconds, you're trying to ventilate babies with rates of 6 to 12. And they're not going to do very well. We typically use this range over here, between 2 seconds and 1 second. And here you can see the corresponding rates. And when I set my backup rate, which is the rate the baby's going to be ventilated at when they stay apneic, I usually try and match it. So if I have the baby on backup settings with a rate of 30, I'll put them on a 2-second apnea time. If I'm all the way up to 50, I'll use a 1.2 apnea time, so that I'm just using one concept of backup rate. We did a study where we looked at comparing an apnea time of 2 seconds to 5 seconds, and then we interchanged it, and we looked at the clinically significant events and what was going on with the babies. The white is 5-second apnea time. The green is the 2-second apnea time. You can see that with 5-second apnea time, they go into backup a whole lot less. Their time in backup is a whole lot less compared to 2 seconds. But even in 2-second apnea time, they're in backup less than 10 seconds. In less than 10% of that minute. So that they're still getting 56 seconds out of every minute is in spontaneous respiratory effort. But the key here is when they were on a 5-second apnea time, they had far more Brady's and DSATs per hour than when they were on a 2-second apnea time. And what we showed was a rate of 30 was better than a rate of 12, which I don't think surprises anyone, because if you've got a baby that you're ventilating with a rate of 12, that baby is just not going to be clinically very stable. So when you're looking to set up both in NAVA and in invasive and non-invasive NAVA, we suggest an approach that looks at it somewhat this way. the NAVA level you want to titrate to the baby's comfort, and for the EDI peaks to sit somewhere between about 10 to 15 microvolts. If the baby has increased work of breathing and the EDIs are high, go up on your NAVA level in 0.5 increments until the patient's comfortable and the EDI peaks are coming down to less than 15 mostly. If the patient is comfortable once you start and the EDI peaks are less than 5, decrease your NAVA level in 0.5 increments until the peaks start to come up. Set your pressure alarm high enough to allow recruiting breaths. And if you keep hitting the pressure limit, you need to ask the question, why? Why is this baby looking to take such really large breaths? And what do I need to do about it? Does the baby have a pneumothorax? Is there a mucus plug? Is the tube displaced? You ask that question. And if everything is fine and the baby has some atelectasis and just needs to recruit, raise that peak pressure limit. Apnea time should be short enough so that the patient goes into backup before he clinically decompensates. And the backup settings should be set in a way to maintain clinical stability if the baby remains apneic. So our initial settings we suggest is to start at a NAVA level of 2. I talked about the break point, and just having done well over 1,000 babies on NAVA now, I can tell you that 95% of them are very happy starting at a NAVA level of 2. Occasionally, it's a little bit too much and you have to back off, and occasionally it's not enough and you have to go up, but the majority happy with 2. PEEP, whatever you use in your unit, approach it the same way. Your EDI trigger at 0.5, that's the factory setting, stay with that. And then your backup support, you just want to pick pressure to ventilate if the baby's apneic, so 18 to 22 roughly for invasive and a little higher for non-invasive. Set your rate at physiologic levels like you would on conventional ventilation, and your I time the same way. We start with an apnea time of 2 seconds. If the baby's stable, we leave it alone. If the baby is having spells, we will go shorter on the apnea time in increments all the way down to 1 second. These alarms are very important. We set that pressure alarm at 35 to 40. The PEEP, respiratory rate, minute volume, and sound level is pretty much routine NICU policy, and we would suggest following it. But the other 2 alarms that are very important, one is this leakage alarm. With non-invasive NAVA, it's not available. With invasive NAVA, turn it off, or it'll alarm a lot. And most importantly, this no patient effort alarm must be turned off. This no patient effort alarm goes off every time the baby goes into backup ventilation. So picture that on conventional ventilation, every time the baby gets a controlled breath, which can be pretty often, the ventilator would beep. You don't care about that in conventional ventilation because the ventilator never beeps. And therefore, you have no reason to care about it with NAVA ventilation. Turn that alarm off. The ventilator will run extremely quietly. Remember, this is not going to affect how NAVA works, and it's not a monitoring thing. You still have a heart rate, respiratory rate monitor. You have a SAT monitor on. Patient safety is not an issue at all. This is just a nuisance alarm that will drive the nurses and therapists crazy. If the baby's not doing well, how do you increase support? First thing you do is always check catheter placement and adjust it if it's not in good position. If the baby's got some acidosis or hypercapnia or there's increased work of breathing, optimize your caffeine, decrease your apnea time. If the baby's mostly in NAVA, go up your NAVA level. If the baby's mostly in backup, increase your backup. And remember to decrease sedation. Babies on NAVA typically are synchronous and don't need sedation. If your EDI min is constantly high and your FiO2 is high, you may want to consider increasing your PEEP. How to wean NAVA? If you've got a good blood gas and you're mostly in NAVA, keep on decreasing your NAVA level by 0.5 centimeter of water per microvolt increments until you get to 1. Then go ahead and extubate, start at a NAVA of 2, and wean all the way down until you're onto CPAP. If your blood gases are fine and you're mostly in backup ventilation, back off on your backup ventilation. Optimize your caffeine, decrease sedation. If your EDI min is low, wean your PEEP. If your EDI min is high, but the baby's fine, leave it alone. If your FiO2 is high, as we mentioned earlier, consider increasing your PEEP. Once you've reached these low settings with a NAVA level of 1, you may be ready for CPAP, and you can also wean down to 0.5 or 0 if you want to. And then any deterioration on CPAP, look to go back to non-invasive NAVA if necessary. So there are no randomized control studies looking at long-term outcomes. So what I'm going to show you in the last 5 minutes here is the best available evidence from our hospital. So we are a hospital that uses NAVA almost exclusively. And we also belong to VAN, and we belong to the less than 1,500 gram database. And I'm going to compare us to type B NICUs. Some important time events. In 2008, we moved into the new NICU. In 2008, we also got NAVA. In 2009, we joined the Ohio Perinatal Quality Collaborative, where we looked at line infection reduction, which of course helped our infection rate and improved our outcomes. And in 2010, we got NIV-NAVA. So to start with, we looked at babies, any ventilation that has come, and this is from 2007 all the way to 2023. And as I collected this data, I was horrified to see back in 2007 to 2009, we ventilated almost 80% of our small babies less than 1,500 grams, which was really quite appalling to me. And then as we've got better at non-invasive ventilation and management with CPAP, you can see that we now well below 50%, around 45% of babies are getting ventilated. Non-invasive ventilation has gone up significantly. We were ventilating about 25% of our babies in the beginning, and with NIV-NAVA now, we're in the 60 to 70% range of our babies are getting non-invasive ventilation. Conventional ventilation, those who are failing and needing, after early CPAP and needing to be intubated, in the beginning, if you failed CPAP, if you got early CPAP, you had almost 100% chance of being ventilated. Whereas now we're down to less than 25% of our babies who require early CPAP go on to be ventilated invasively. These gray lines over here are the 25th and 75th percentiles of the collaborative, just so you can see where we rank. The amount of chronic lung disease we see. So you can see the collaborative is somewhere between about 15 to 35% is the average of, is the interquartile percentiles here. And we are sitting close to the bottom, sitting around 10 to 12% of chronic lung disease. Last year, we had one of our best years at about 9%. So we are doing pretty well for that. Our death or morbidity, keeping in mind that if babies die early, they don't get chronic lung disease, but you can see our death or morbidity still remains good in the lower quartiles. Survival without morbidities, those that make it through the NICU, the majority of them, well over 60, close to 70% of them are leaving our NICU without any of the major morbidities. The type of chronic lung disease we see. Most of our babies going home with chronic lung disease are oxygen at the time of discharge. Very few babies are on high flow nasal cannula at 36 weeks. Very few on CPAP, 5% of our babies at 36 weeks. Very few on non-invasive ventilation, about 2%. And with conventional or invasive ventilation, which is the only way that the VAN network allowed me to access this, you can see that we have multiple years where we've had no babies ventilated 36 weeks, but otherwise very low amount, 1 to 2 babies a year that remain intubated at 36 weeks. So in conclusion, NAVA is proportional for initiation, size, and termination of the breath, and therefore provides excellent synchronous ventilation. It provides proportional assist on a breath-to-breath basis, so this truly is personalized ventilation for that baby, for that breath. NAVA level distributes the work of breathing between the patient and the ventilator. The higher the NAVA level, the more work the ventilator does. The lower the NAVA level, the more work the patient does. NAVA responds to the patient's respiratory drive and supports the patient's respiratory effort. Set the peak pressure limit high to allow the patient to take adequate recruitment breaths. Set the apnea time short to provide backup support during respiratory pauses so that the ventilated patient receives a minimum rate. If the baby's unstable, always check the catheter positioning first and use your clinical assessment, your work of breathing primarily, and then your EDI values and blood gases secondarily when you're assessing the patient. So I am convinced that NAVA works in neonates, but that's not really the question. The question really is, does it make a difference? So large multi-center trials are needed to answer some of these questions. Does NAVA prevent intubation, or does it decrease time on the ventilators? And currently, we are enrolling babies in about 18 centers around the country and a couple of centers in Canada, where we're comparing non-invasive NAVA to NIPPV for babies that are being extubated. So for the fellows who are part of this trial, we're trying to get to this answer if synchronized non-invasive ventilation is better than asynchronous non-invasive ventilation post-extubation. Does NAVA decrease the incidence of chronic lung disease? Our DIVA trial will not address that, but that's an important question that needs to be answered. And overall, will NAVA improve outcomes? Thank you very much. And I will open it for questions. I'm going to go ahead and stop sharing my screen.
Thank you so much, Dr. Stein. It looks like possibly Armando got pulled away because he's on clinical service. So I'm not sure if there are any questions from the audience, but I would love to ask you about your impression. You mentioned that there are clinical trials now going on to see if there's a difference between infants who are receiving standard ventilation or non-invasive or NAVA. You mentioned that was in Canada and some US NICUs. I mean, to me, your argument is so compelling. What do you think is some of the reason this hasn't caught on as much? Is it that it's specialized technology and other things? I'd love to hear your perspective on that.
Yeah, this is one of the big arguments that I'm having just in general with the company. I think this is just selfishness on the company's part. NAVA is only made by Gettinger, and they are unwilling to license it to Draeger, to Hamilton, to Avia, to all the other ventilator companies out there. So therefore, unless you own the servo ventilator, you don't have access to NAVA. And as much as I argue that they will never own 100% of the ventilator market, there will always be room out there for other ventilators, which are fabulous ventilators. They really had an opportunity to offer this to every baby out there if they would just license the technology to the other companies. But clearly I'm not a businessman because I've got nowhere with my argument.
Yeah, I think that goes for a lot of us in neonatology, or at least. If there are any other questions from the audience, people feel free to come off mute or send a chat.
Right. So I've got a couple of questions here. The first one is, how do you troubleshoot when the catheter is not picking up the signal well? Well, I must admit it, today, this doesn't happen to us very often. But the reasons we do is, first, if we have a poor signal, we want to make sure that it's not real, that this baby has a very poor respiratory drive. So we make sure it really is a signal issue and not a baby issue. If it then is a signal issue, then one of the reasons that this can happen is that the baby has a lot of reflux and the food is interfering with the interface between the electrodes and the esophagus. What we typically do then is we will rotate the catheter a little bit and try and improve the electrode esophageal interface. Usually it is not a big problem for us, and the therapists and nurses just do a lot of wiggling until they manage to get it to work. Second question, I wonder if you've had any experience using NAVA with a level of 0 as CPAP with apnea support. In fact, we have a couple of papers published on it. The most recent was just at the beginning of this year, and we have coined this NAVA PAP. I think this is a fabulous way to use NAVA for babies that are having apnea of prematurity. So what this principle is when you put the babies on a NAVA level of 0, they essentially get no support above PEEP when they breathe. I say essentially because they get a tiny bit. They get a 2 centimeters of water above PEEP. So when they are NAVA level of 0 and they breathe, they get CPAP. But when they don't breathe, then they go into backup. So this is truly CPAP with backup. The problem with NIPPV is they get support when they're apneic, but they also get support when they're breathing. And most of these babies don't need that. So we have really embraced NAVA of 0, or what we call NAVA PAP. And I would say that the majority of our little feed and grow babies with apnea of prematurity sit there on NAVA PAP with minimal support. So CPAP most of the time, just occasionally going into backup when they have apnea. Any more questions? Right, so while I'm waiting for someone to speak up or for someone to put something in the chat box, I just want to say a couple of things. For the fellows who are in all these, which is most of you, in these high-powered academic programs, our institution actually, although affiliated with a university, we are a private practice that have chosen to do this research on our own with it. So just, there's lots of opportunities out there that even if you're not in a high-powered academic center, don't give up on your research goals or your research ideas. There's always opportunities to do these things out there, and always an opportunity to, add to the literature and try and improve the care that we're giving. And if any of you want to do it with us, we're recruiting. Hello. All right, back to the chat box. Another question about NAVA PAP. Does the NAVA level of 0, does that increase our intermittent hypoxemia? Very much so. Our clinical experience, as well as the studies that we've published, have shown that if we have them on a NAVA level of 0, our clinically significant events drop significantly. And our DSATs are either almost eliminated completely, or they far quicker and far shallower than they were when we were just on straight CPAP. Any more questions?
Thank you so much for this talk. It was really thought-provoking and very helpful.
Thank you all.
Bye-bye. Thanks
Bye-bye.
again. Thank you, Armando.